So I want to talk to everyone about contact tracing. It's been getting a lot of attention in the media, and I want to tell you how public health uses contact tracing really on just a daily basis. So contact tracing has been a fundamental public health practice for over a century, and it's an important tool in interrupting the spread of infectious diseases. I think most people are most familiar with contact tracing in the setting of sexually transmitted diseases or tuberculosis or even measles, but we use it for almost every reportable infectious disease that is here in Arizona when the disease spreads from person to person. So how does it work? When someone gets tested for COVID-19, the specimen is collected by the provider and sent to a laboratory. It takes up to 3 days for that specimen to actually get to the laboratory, depending on where that laboratory is. So the lab then runs the test and sends that result electronically back to the Arizona Department of Health Services through electronic laboratory reporting. Once ADHS receives that test result, it gets automatically loaded into a system called MedSys, which is our electronic disease reporting system. And that state reporting system feeds automatically to the county, where the infectious disease investigators and nurse epidemiologists can download that information from the reporting system. And that's where the Maricopa County investigator first learns about a positive case of COVID-19. So the investigator will review that result, pull the information from the system, and then start the case investigation. So the way it starts is the investigator contacts the case and does an extensive interview. They ask the case about all of the people in their household because we know that people in the household are at the highest risk of being exposed and infected with COVID-19. They also ask about healthcare workers who saw the patient while they were infectious and who treated them because we know they're also at higher risk, particularly if there were any issues with personal protective equipment. And they also find out who else was in the facility during the time that the case was there while they were infectious. Finally, they ask about community contacts based on how much time they spent with the person while infected. So the investigator is trying to discover who of the contacts could be at risk for exposure. And that means that they spend at least 10 minutes within 6 feet of the person, starting at the time period 48 hours before the infected person ever developed symptoms. And that's what we've learned during this process, is that people are infectious before they develop symptoms, and that's why we go back those 2 days. And the investigator literally walks through every single day, starting those 2 days before symptoms began, and walks through every activity, every meal, and finds out who the person was involved in, how long they interacted with that person, what type of interaction it was, to make a determination about whether that individual would be considered exposed. As you can imagine, this interview can take anywhere from 1 to 3 hours, depending on what language the person speaks, how sick a person is, how long that time period is that the person was infectious and out in the community, and how many people they had contact with. So during this time, investigators are part public health, part detective, and part social worker, trying to establish rapport with this person that they've never met and trust, and at the same time trying to cover as much information as possible without judgment. They also have to interpret the information as they're hearing it from a technical standpoint so that they can ask appropriate follow-up questions and get the full picture of who was exposed, how they were exposed, and what level of risk there is. And this is especially true when investigators have to ask questions that might be personal to the case, such as, did you go to work while you were ill? It's important that they get truthful answers and that people know that they are not being judged and that this information is being used purely for public health. So during the interview, the investigators are taking note of all of the locations of all the people who could have been exposed while the person was infectious. And they asked the case to provide contact information for the people mentioned during the interview who are at risk for exposure, including household contacts, healthcare workers, and anyone who may have treated them. Contacts who the investigator considers to be at risk for exposure to COVID-19 are then called by that same interviewer and given information on what symptoms to look for, told that they were exposed recently by someone who was infected with COVID-19, and what they need to do if they develop symptoms to get treated and to avoid exposing others. It's important for everyone in the public to know that these conversations are confidential, and when they're calling the contacts, the investigator never mentions the name of the person infected, and they also don't provide information that would lead somebody to figure out who infected them, or who exposed them. So we take confidentiality very, very seriously, even during the interviews of the contacts. Healthcare institutions who treated the exposed persons are called to discuss which healthcare providers might have been exposed and who else might have been in the waiting room or in the facility. And then we check up on the close contacts to see if they have developed symptoms. Depending on how high risk the exposure is, we might check in with them daily, or we just might check in at the end of the risk period when the person might develop symptoms and experience the disease. So those who are quarantined, so restricted to their homes so that they don't affect others, tend to be checked on much more frequently, usually daily, to make sure that they have access to food and health care. Anyone who develops symptoms is given instructions on how to seek health care safely without exposing others in the doctor's office, urgent care, or ER when they go. And then if that person tests positive, they're considered a case, and then they are called by an interviewer, and the whole process begins again. So this is traditional public health contact tracing. About a month ago, as cases rapidly increased and the stay-at-home order went into effect, we changed our investigation process to case-mediated contact tracing. And what that means is that we still interviewed every single positive case reported to public health, but we worked with the case to reach out to their contacts and provide them with all the instructions that we just described in writing. Since COVID-19 began, public health has doubled the amount of staff that we have doing investigations. We're up to about 25 now. And this includes 5 staff members that are dedicated 100% of the time to supporting long-term care facilities, which includes skilled nursing facilities, nursing homes, group homes, assisted living, all-techs, and rehabilitation facilities. There are far more than 500 of these in the county, so we have an incredible amount of staff time dedicated to just these facilities because we know those residents are at the highest risk of getting severe disease from COVID-19. We're currently working on scaling up our capacity from where we are now to 8 to 10 times that capacity, so that we can facilitate doing traditional contact investigations as soon as the testing becomes more widely available. And we know that those case numbers will continue to rise with potentially hundreds of case investigations per day. So we hope that as testing becomes more available, we can scale up, and once the governor's orders are lifted, people are going to have a lot more contacts during these investigations, and it's going to take a lot more staff to manage all of the contact tracing. And we hope to have more specific information on that plan coming very soon. Thank you.